Let me pull it up so we get that information in front of us. There looks to be a lot going on, and not just involving your bones, but involving your lung primarily, and some of the lymph nodes around the lung. So we call the hilum, where the lung attaches to the middle of the chest, and the mediastinum middle structures. Based upon what the read is, interpretation of lung cancer as a primary source of all of these findings. So we'll look at the PET CT together. But we need to try to get a biopsy to prove it, to know what type, what histology. So this.
I'm sorry, you have to do what?
Get a biopsy.
Okay.
Because we want to make sure we can tell the exact histology. There's different types of lung cancer, and so you treat them differently. But there's also concern. Sorry. What did I do wrong? There's also a concern making sure to protect the spine, because you worry about any compression on the spinal canal or spinal cord. So that usually shows with neurologic dysfunction, numbness, toes, numbness, weakness, any problems with motor function, loss of sensation in your feet.
I do have neuropathy in my feet. It never really got that bad. I mean, sometimes it feels like I'm walking on packs of hot dogs. And it's been many years. I mean, probably 12 years ago I was diagnosed with it. And I went to a neurologist and he did that electrode test. Other than that, my two fingers, my pinky and the one next to it on my right hand, have been a little tingly lately. And I think I mentioned that in our other appointment. But that's the only tingling in my hands. Can I get a copy of the report?
Yeah, definitely.
Thank you.
So here's our scan. Alright, so probably the lights on, probably what's best for the camera. So look at a CT scan. We're trying to use a CT fused with PET imagery. Okay, so CT is using anatomic, or looking at structures. So a slice is like a loaf of bread, making cuts through the body, and so more of a sagittal films, cross-sectional films. Okay. So with CT imaging, we got white is bone, gray is kind of soft tissue. I'm gonna scroll down a little bit. So gray would be like soft tissue here that orbits the eyes. Black would be air, kind of nasal, in this case nasal passageways. It's fused with brain imaging. It's fused with PET imaging, where you use radiolabeled glucose. Radiolabeled glucose has activity, and the activity is where there's increased uptake. And so glucose or sugar is what your cells use for energy substrate. And so minimal activity is here, black, red, orange, yellow, white, more intense activity. And so,
I'm sorry, say that again?
So that's more intense activity up this vertical scale. And so the scale of activity here in the brain, there's normally a lot of activity, that's normal. But it gives you a concept of what activity would look like. So that's what you expect to see in the brain, a lot of activity. Okay, that's normal. But if we scroll through, so we make cuts down the body, it's going from here now, just getting from the orbits, the eyeballs, further down bridge of nose, and work our way down. We're going to leave the brain parenchyma. So now if we see much of activity, it's going to be something probably abnormal. Okay? This is the left side, that's right side, so it's like you're looking at somebody's, not a mirror image. So we start looking and saying, well, there's some activity here on the edge. Just go with the imaging. Here on the side, the right side, the pedicle here, and this is probably an upper thoracic spine.
So that circle there is the spine?
So, correct. We'll go downwards so easier, but yes, this would be kind of this circle here. That's your vertebral body, spinous process, but in here is where your spinal cord could be, like gray area, sorry, gray here. And so that's what you want to maintain, that stays in good form and not any kind of compression. So if you look here, this is where your insert of your collarbone is on the left side. That spot there is in the bone. This is your shoulder.
So there's cancer in the bone in my shoulder?
Mm-hmm. And this is some cancer here, again in the scapula, but maybe on both sides too.
Yeah, I had a lot of pain in my scapula on both sides when I was in the throes of this.
That's what we're seeing on both sides.
Yeah.
So right, left, here in the sternum shows our insertion site for our first rib.
Would they have not noticed the shoulder when she broke her shoulder that time before she moved here?
It was
Maybe
2
not.
years ago.
And it probably wasn't, it's probably unrelated.
How old do you think this cancer is?
That's a great question. There's a lot of that activity. So if you're saying based upon metabolic activity, it may be just measured in months. You know, 6 months, 9 months. Sometimes it's hard to know. When you get a biopsy, you say, well, is it high grade growing fast? And they say, well, it's maybe a shorter time frame than if it's low grade, slow growing. But we need biopsy to kind of prove that. So here we're seeing it again. That's part of that posterior, the scapula. Here, vertebral body. This is where I start worrying a little bit about. Here's your cord here. Make sure not impingement on the cord or any nerve roots, but just kind of mid-thoracic spine, T4, T5 level. You can see in this pedicle here, there's some activity. Here again, the vertebral body. This is where they think that the primary site may be. So this is.
And that's in my lung?
Correct. So in your right lung, right near the central portion of it, kind of a little bit hidden behind the heart. Right there.
You know, I've had pain underneath my breast on the right side primarily, but it I always had to put an ice pack on it when I was, you know, really pained. And is that where it's located?
You probably wouldn't feel that. I was looking at, you know, breast tissue and breast pain. We may find that it's up here.
Okay.
It's a little higher up, but
Well, it was under my breast.
yeah, so maybe it's a little higher. So scapula, we'll look. Definitely saw. Here's the area around the lung, the hilum, and then we'll keep looking kind of posterior. Here's a lateral right rib lesion, more anterior, but still on the right side, rib area. Vertebral body again showing some involvement. See much else in the anterior ribs. This looks like this is the liver that comes into view. This is the heart, but the liver shows some uptake there.
Great.
And then that's normal for kidneys, that's nothing. But these spots here are not normal.
Is that my coccyx?
Not quite. Still lumbar spine, maybe lower thoracic, but definitely higher up than the tailbone. So now here we get to more tailbone here. This is an issue of spine, but definitely some involvement there on the right side. Here as well. And here posterior and there. So this is the left side there, around the hip. Here the right side. And they've commented on this too. There's a fracture here.
Oh, really?
Yeah, on this maybe sacroiliac. We see this is malaligned right here.
Huh. Could that be from a fall?
Could be, but
I'm in no pain from it.
See, it's becoming more linear here.
Yeah.
You know, you walk wobbly, like a penguin. I wonder if that causes that.
So the question is then, we certainly need more tissue sampling. We want good, adequate tissue so we can get the right diagnostic test.
Okay.
Based upon the location of the lesion in the lung that's kind of hard to get to without doing a bronchoscopy. And I was looking more, and it's not huge, but that lesion in the liver might be a better thing to try to target. And it's not a large target, but we're looking for something to get from soft tissue that's easily amenable to biopsy to help give us a diagnosis and then help us kind of get this treated. Here's our spot here.
So the cancer that I have all came from the lung?
More than likely, that's the suspicion, yes.
Okay. And what is the prognosis? I mean, am I going to have
So-
6 months, a year? I mean, is there any...
So we don't know, because we don't have a tissue diagnosis. We don't have but small cell, non-small cell, and then all of our prognostic indicators that can tell us, is it respond to immunotherapy? Is it something you would give targeted therapy for that would be more oral regimens? So there's a lot of treatment regimens that we can look at. My primary concern is obviously number one, getting a diagnosis, because that helps with prognosis and certainly with treatment plan. It is stage 4, whatever this is, and it looks like it's from the lung to the bones and likely in the liver. So some of the stuff that's recommended is getting a brain MRI, because the PET scan doesn't look at the brain really well because there's so much activity. And so it's recommended to go ahead and get a brain MRI as well, just to ensure there's no evidence of cancer there.
Okay.
The other thing is with the spine being narrowed, we worry about compromising spinal function, so that numbness we're having is probably neuropathy, but you don't want to have anything that could impinge the cord and cause cord compression. That can lose motor function, and that's like you can't walk or have trouble avoiding. You don't want to have new problems develop. I know you feel well, but this is kind of prevention. So it'd be good to meet with a radiation oncologist who can radiate an area to help kill any cancer cells that could be trying to impinge on the spinal cord, as we need to get the information about how we're going to treat this and what this is.
Okay. So what's the first step I should do?
So there's 3 things: brain MRI, radiation oncology referral for treatment to protect the spine, and a biopsy of that liver lesion. Needs to be a recommendation, because we can do a core biopsy and get more tissue than doing one, although there's much more tumor burden in the lungs. The hard part is getting to it, because to get to the lungs you have to go through a bronchoscopy, meet with our pulmonary medicine doctor, get all that arranged, and it just takes time. You have other large lesions in the bone, and they may ultimately say, hey, let's target that for ease. But I worry about decalcifying the tissue and getting all the other prognostic tests I'd like to get. It's not as hard to do from bone
So
sampling, but this is the primary site.
your office would coordinate all this and just call me with the date and the time?
Correct.
Okay, that's
So
fine.
this is your airway here centrally, and this is very proximal to it, very close to it. But getting down there and with a scope, and they can usually only do small passes, and so you're not getting a lot of tissue each time. And so it's, although it would give us the answer, it's not my first ideal way to do it. So doing an endobronchial ultrasound usually doesn't give you more than just some fine needle aspirates versus like a core biopsy, something with more tissue that we can look at.
What is that appointment you have in November? There
That's
was
a rheumatologist.
Hmm.
That can be changed. I will take any day and time that you have. Now, are all the doctors you're talking about doing these things except for the MRI here?
They would be in different locations, like if you're doing the radiation appointment, and maybe you're talking about trying to do it at the Berkeley Hospital. Do you know where that is? The Roper Berkeley
Yeah, the
Hospital?
new one? Mm-hmm.
On Callan Boulevard, yeah.
Yeah.
And I'm sorry, that would be for what?
Radiation appointment.
And is
to
that
do
one of your
MRI there, too.
doctors, or
What's that?
is that one of your practice doctors? or-
Different practice, but there's a whole different field of radiation oncology, and so I know
Okay.
them well, work together all the time. Dr. Beatty would be
Okay,
who you'd see. He's great.
okay. Well, I guess it wasn't a mistake. I guess I could have stopped smoking 40 years ago and would have been better off.
Well, we don't know if that caused it. It's a risk factor, but it's what we've got now, and let's see what this is. We obviously need to get something to treat this to go the other direction.
Yeah.
To make this get better.
Do you think it is treatable?
Oh yeah.
Oh,
Yeah.
good.
There's no question about treatment, but I think your question was very valid. What's prognosis? What's the likelihood? What's the long-term success rate? You know, what are we looking at? And if it's small cell lung cancer, it's a more aggressive form than non-small cell. So if we see that, we really need to jump on treatment sooner.
Well, I'm ready to do whatever you need to do.
So let's find out what this is.
Okay.
Okay.
Well, I
That's-
appreciate everything,
Of course.
you know, with the explanation. And this is good that I have it on video because I want to watch it again,
Yeah.
you know, obviously. And if I have any questions,
Yeah, let me know.
I'll let you know.
The report's there too.
Okay.
Disposal, I know it's maybe technical, but I think together we'll get the right answers.
Okay.
Okay.
So how long do you think it'll be before I hear from somebody about scheduling?
It should be more than 24 hours.
Oh, excellent.
Yeah.
Okay,
Make
good.
sure it's just this time.
Excellent.
It's where you do
Okay.
the left lobe of the liver,
Yes.
biopsy, radiation to the
Thoracic
spine,
spine,
and MRI of the brain.
Okay.
Thank you.
Okay.
Yeah.
That's good.
Nice
I'll be
meeting you.
okay. I've talked it out, you know, talked to my friends and family,
Let's
and
find out what it is, right?
Yeah.
We still know that looks bad. It's probably stage 4 lung cancer. There's so much we don't know. That
right.
helps guide our treatment. And immunotherapy can do wonderful things in this type of disease. So let's just find out what it is.
Okay.
And I'm not ready to lose my last sister.
Yeah, we lost our other sister to COVID. Mm.
Me neither. So let's
Thank you
find out
very
what we-
much.
Okay.
I really appreciate the
Of course.
expediency you're doing this. Is that a word, expediency?
No,